Welcome everyone to today's PHSSR Research in Progress series. Our theme today is kind of quality, cost, and the value of public health. Our specific study we're looking at today is a centralized remind and recall system to increase immunization rates for populations of young children. This is a comparative effectiveness research trial. And our presenter today is Allison Kempe, MD, MPH. Allison is the director of the Children's Outcomes Research Program at the Children's Hospital of Colorado. She's a professor of pediatrics at the University of Colorado School of Medicine and also the Colorado School of Public Health. She's co-director of the Colorado Health Outcomes Program and director of an ARC-funded Center for Research and Implementation Science and Prevention, or CRISP. And with that, Dr. Kempe, would you like to start?
Hear me okay?
We certainly can.
Okay, great. So I'm going to be talking in a general way about increasing vaccination about young children. And let me just make, whoops. Sorry, I was told to advance with something and it's not working. Okay, great. So I probably don't need to sell this audience on immunizations, but basically these are the statistics about the percent decrease in disease related to the various immunizations we give during childhood. And immunizations are basically second only to clean water in terms of their effectiveness and cost effectiveness. Here's a different graph showing the same thing basically, and we see the nice little bump that we're getting recently in pertussis, and if this line for measles were extended, we would now be seeing a bump in measles, unfortunately. So how are we doing? Back in 2011, we were at 68.5% of 19 to 35-month-olds fully immunized, with the Healthy People 2020 goal being 80%. So what are the problems? And I've spent a lot of my career looking at a lot of these problems. I'm not going to talk about all of them today, but there are a variety of barriers, financial ones, which should be improving now related to the Affordable Care Act, access to care issues, lack of awareness, which we are going to be dealing with today, infrastructure, regulatory issues, the complexity and expansion of the vaccine schedule, which again we are going to be talking about today. And it's important to note the incredible increase in the number of vaccines in the last 25 years. And then there's vaccine hesitancy related to either misinformation or safety concerns, and that's certainly becoming more of a factor, although total vaccine refusal remains low. So I'm going to be talking about a trial we did that compared two pragmatic approaches to trying to increase immunization rates for young children in total populations. And as probably many of you know, reminder recall, which is the use of postcards, letters, or telephone calls to inform patients they're due or overdue for immunizations, is one of the most evidence-based methods for rapid increases in immunization rates. The Task Force on Community Preventive Services recommends this as one of its strongest, most evidence-based methods. And with new technology, this can be automated using immunization information systems or immunization registries, and all states now have immunization registries. Reminder recall has been shown in a lot of trials to be effective in increasing rates, but only 16% of physicians nationally are doing this at the practice level. So we reasoned a number of years ago that maybe population-based reminder recall, if it was conducted centrally by public health departments, could offer advantages over this practice-based method. Number one, reducing burden of conducting reminder recall by the practices, and also the potential of reaching children who did not have a usual source of primary care. So our objectives in this trial were to compare effectiveness and cost effectiveness of two methodologies that are sort of population-based population-focused. One is the population-based method in which we would conduct reminder recall centrally using the state health department, the CIIS, Immunization Information System, or state registry, in which we would try to both train and incentivize practices to conduct reminder recall at the practice level. So we basically we took 14 Colorado counties, we stratified by urban and rural, and then randomized within these strata. Actually, the randomization was more complex, and I'll go into that in a minute, but basically within those strata, we randomized to practice-based or population-based approach at the county level. I'm not going to go into the randomization in great depth unless you'd like to discuss it later, but basically we did use something called covariate constrained randomization, and this has been a very helpful technique for pragmatic trials in which you need to do a cluster randomized trial, but need to assure that there's very good balance on a number of factors. So this is something we did, and we balanced basically things like the percentage of pediatric versus family medicine practices, the socioeconomic level of the county, their baseline immunization rate. We balanced on about 10 different parameters, so that was very helpful in making sure we had balance. So just to clarify, the study population for both intervention arms was obtained from the State Immunization Registry, the CIIS. And in our state, patient names, addresses, and immunization data are automatically uploaded from birth statistics into CIIS. And then, of course, children immunization received are uploaded into the registry from the practice sites. Now, registry participation in Colorado is not mandated, but approximately 90% of providers to children do use the registry in Colorado. So then we downloaded names and addresses of children 19 to 35 months that appeared to need one or more immunization with all 14 counties. Now there's some obvious limitations to denominating the populations in this way. One is that kids obviously move in and out of the counties, and they may still be in the registry with and associated with a particular county when they're no longer there. But because we did it the same way for both types of intervention arms, we felt that this was the fairest way to denominate all populations. So just going over the intervention strategies, in the population-based counties, the reminder recall was conducted centrally by the state health department, and this was, the study I'm talking about was June through September of 2010. Up to 3 mailings were sent to children 19 to 35 months who needed immunizations, and the notices suggested parents go to their primary care provider for immunization, or if they didn't have one, to the public health to a public health immunization site, and these were worked out with the county public health departments within each county. In the practice-based recall counties, all practices were invited to attend a web-based reminder recall training prior to the recall, and we actually tried to contact each practice up to 8 times. We suggested at these trainings that they use the same methodology, i.e. 3 mailings from June to September of 2010, and we offered to pay for the mailings for all practices who did reminder recall in this time frame to that age children. So we felt this was about the most a public health department could do to try to incentivize practices. So in terms of the statistical analysis, we did have to account for the clustered nature of the data. So we used a mixed effects model. 2 models were conducted to assess the association between the intervention group and whether or not a child became up to date or received any shots. So those were our 2 major outcomes. And we had used fixed effects for both models, including county baseline up to date rate, rural urban status of county, and whether or not the site of last service did reminder recall. And the random effect in both models was the site of last service. We also did a cost assessment. In the population-based reminder recall counties, we could pretty accurately estimate staff time for training and implementation, staff time for updating bad mailing addresses, and mail and printing costs for up to 3 mailings. In the practice-based reminder recall counties, although we recommended the method for doing reminder recall, they actually could, they obviously could make their own choices. This is a pragmatic trial, so that's one of the things we can't control. But we did contact them when they pulled a list, which we could tell when they pulled the list. We interviewed them then about the staff time they spent to do reminder recall and the mailing costs or cost of telephone calls. So one of the major take-home messages of this trial is the reach of each intervention. This is the practice-based reminder recall arm and the population-based reminder recall arm. In the practice-based, there were 195 practice sites. Only 10 conducted reminder recall, despite the fact that we offered to pay for it. That meant that only 5% potentially could have received a reminder recall. That's assuming 100% got it. In the population-based counties, we actually were able to figure out exactly who got the reminder recall in terms of not having returned mail. And so 85% was our estimate of reach. So that's the biggest take-home message, is that we could not incentivize practices to do this. So the percent that received any vaccine within 6 months of those needing it was 32% in the population-based compared to 23% in the practice-based, with an absolute effect difference of 9%. These are similar results for the percent brought up to date, 19% versus 13%, an absolute effect difference of 6%. And I want to underline this is within 6 months, so these are pretty rapid changes. This is a subgroup analysis within the practice-based counties of the percent brought up to date. And this is looking at the issue of, is it that reminder recall, if it's based at the practice, doesn't work? And the answer is emphatically no, it does work. So here are the 10 practices that did practice-based reminder recall, and they had up-to-date rates of 24% versus the percent that did not do practice-based reminder recall, who had a rate of 12%. And if you compare the practice-based reminder recall to the population-based one, actually, it looked as if the practices that did reminder recall were more effective than the population-based method. Now, it's important to remember this is 10 practices. They were not randomized, and they were likely to be quite atypical and to potentially have atypical patients. But in any case, it was not less effective if they did reminder recall. Here's the multivariable models showing that they had adjusted odds ratios of close to 1.25. And the costs were one of the biggest take-home messages, where the costs were very different. For the population-based reminder recall, this is the total cost, cost per practice, $215 compared to $1,300 for the practice-based. The cost per child receiving one or more vaccine, $10 in the population-based versus $38 in the practice-based. And per child brought up to date, $17 versus $62. Now, there's some important limitations. As I said, the populations were impossible to completely accurately denominate, but we believe that since the same methods of approximation were used in both intervention arms, this is probably not a threat to validity. The population-based reminder recall was hampered by many inaccurate addresses from vital statistics, so it could have been a whole lot cheaper if we didn't have to spend so much time tracking down bad mailing addresses. Practices may have, in fact, conducted reminder recall after the 6-month period of follow-up, despite the fact they weren't going to get incentives. So if we'd held on for longer, maybe we would have seen less difference. And finally, costs were based on personnel report rather than direct observation in the practice-based arm. So in this study, both practice-based and population-based reminder recall were effective. Practice-based may be slightly more effective when practices participate, but we can't really say this because those were not randomly distributed. Overall, at the county level, if you're approaching it at the county level and trying to increase population-based rates, the population-based centralized method was much more effective because of lack of participation of practices, even if they were incentivized. And importantly, the cost per practice or per child vaccinated were much lower for the population-based reminder recall approach. Now, based on this, our implications were that the centralized approach was more effective and less costly. However, we thought, based on these data and also data we got from surveys, both parents and providers, that the optimal approach might involve collaboration between the practices and public health departments, in which the reminder recall notices could appear to come from both. Could potentially be less costly if practices were involved actively in helping to update addresses. And we also felt we needed more information regarding the acceptability of this from both practices and patient's perspective. So we have done some further studies. We did another large county-based reminder recall, which showed similar results to the first, but in the second trial, we looked at the effect of practice endorsement. And what I mean by this is inclusion of the practice name on the reminder recall notice. So this was similarly a population, a very similar trial, but in the population-based recall counties, this was conducted September through November, centrally again by the state public health department. Reminder recall notices were printed with the county health department logos and the private physician's information if practices opted in for this approach, or what we called endorsed it. And then the reminder recall was the same as what we've talked about previously. So here's the sub-analysis of the population-based reminder recall, the percent receiving any vaccine. If the practice's name was not included, the increase was about 24% versus 31% if the practice name was included, with an absolute effect difference of 7%. And this is similar data for percent up to date. 15% if practice name was not included, and 25% if it was. Now, important to note also, this was not randomized. So there is certainly some selection of those practices that chose to include their name, probably being more effective practices in other ways potentially, and their patients being slightly different in some ways. However, this was roughly 60% of the population that chose to endorse. So, I think that there's a high likelihood this makes a big difference. Okay, so I'm going to stop there to allow for discussion and questions.
Allison, thanks so much. So we've got two folks on tap to comment today. The first one is me. I'm Richard Ingram. I'm a professor in the University of Kentucky College of Public Health in our Department of Health Management and Policy. I've been involved in public health systems and services research and activities for a fairly long period of time, and currently I work with the National Coordinating Center for Public Health Services and Systems Research on their efforts to integrate various kind of national level data sources looking at public health system structure. Our other commentator is Lisa Van Ramdonk. Hopefully I pronounced that right, Lisa. Ramdonk. Lisa is the Executive Director of the Colorado Association of Local Public Health Officials, is also the Director of the Public Health Alliance of Colorado, as well as the Co-Director for the Colorado Public Health Practice-Based Research Network. Lisa's work is dedicated to encouraging system-level improvements through strategic partnerships, workforce development, peer networking, capacity building, practice-based research and dissemination, and policy development. Prior to her career in public health, Lisa worked in public relations and marketing and has experience with nonprofit and business-to-business communications. She has an MPH and MSW from the University of Michigan. So, Lisa, would you like to start?
Sure. Can you hear me all right?
Yes, we can.
Okay, terrific. So thanks. I'm thrilled to be here to share just sort of a little bit from the local public health practice perspective. We've been involved with Dr. Kempe on this project, on these few projects from almost the beginning, and so have had a perspective along the way, but then, so I'll zoom in a little bit into that, but then really just a couple of comments and thoughts for the group to think about a little bit bigger picture. So first I wanted to start with the concept of public health and primary care partnership in local communities. Obviously a topic of keen interest both in the research community and in the practice community, and both the primary care and the public health practice communities. You know, one of the things that Dr. Kempe did in these projects is really help build relationships within the local communities. In this type of work, you know, she certainly could have just sort of popped in as a researcher, done some work, and walked out the door, and that just isn't how it operated. And what that means is that after the research is finished, there is something more to work with between the public health and primary care agencies and organizations. We know that, you know, there are many ways in which primary care is overwhelmed, and we also know that sometimes it's difficult for our local public health colleagues to articulate very well over the long term what kinds of ways that we can help primary care both meet their individual needs and interests in helping an individual patient, but also to help them think about how they can impact their population of patients and the broader population in the community. And I think this project, these projects, this concept is a good example of that. Despite the fact that the state health department is who did the actual recall, the local public health agencies, as you heard in the description, were connected with early on, communicated with, they talked with Dr. Kempe and her team about understanding the registry situation in their community, because many of our local public health agencies do try to advocate for their practices in their community to work on the registry and put all their information in the registry and sort of operate in some cases as technical assistance to that. And so by the approach of coming to local public health early on and saying, we're going to be in your community and we'd like your help, it was, I think, just really, really helpful, and that will hopefully be sustained. So I think the other piece I think you should know about Colorado, if you don't already, is that we are a decentralized state, so our state health department is completely separate from our local public health agencies. We're also very strong local control, and so we don't often say, yes, that's something that the state health department should be doing. It's almost out of principle, you know. So it's nice to have this kind of work to think about the second topic, which is public health system structure, to think about what are the right state and local roles, and to have some really good research behind what the right roles might be. So it's not about politics or personality or guessing, having some of that. Where is the best place for this public health activity to occur? Certainly it could have been the local public health agency, but I think in this case, we especially saw that at the state health department level, there's just the kind of collectiveness of the work that can make it more efficient, effective, and such. So, you know, one of the remaining questions I have of how we could use this both obviously in the area of immunization, but also in other activities when we think about our public health system structure and what is the right state and local role, especially in decentralized states. You know, I ask you all to think about, you know, what are other areas of work or other public health primary care activities that we could think of similarly. And, what could we think about in terms of actually studying and understanding the sort of comparative effectiveness of where some of these activities could best operate? And then, what might not work better this way? I think one of the thinking games I have right now is thinking about communicable disease surveillance and communicable disease investigation. And there's, where is that best housed within a state? And then lastly, I think after the public health primary care partnership and sort of thinking about public health system structure, the third area that I think about this project in practice is in health reform and payment systems change. And as we continue to evolve how this kind of work, both the immunizations themselves and the reminder recall and the other work that happens around an individual immunization, as we continue to evolve our payment systems, how we think about where this kind of work may be best housed can also evolve. And I would say there's also different incentives that begin to evolve. So when we think about the ACO model, the Accountable Care Organization model, or in Colorado it's our RICO model, are there incentives that we can build into those ACOs to incentivize either that local reminder recall or state level or even at the ACO level? And then I think that there's also tied to that is the funding piece. With our fee-for-service funding models, we've been great at thinking about funding the individual services, but how do we sustainably fund this kind of work that we know at the end of the day really does drive more people to be immunized, which drives greater population health? How do we fund these pieces that support that individual immunization but are not directly that individual immunization, especially if we determine that maybe the most efficient, effective place for that work to occur is not in the primary care office? So just another thing to think about, how we think about the sustainable kind of work. So those are the three areas that I have thought about over time and would be happy to, after Dr. Ingram shares his thoughts, listen to your thoughts about similar.
Lisa, thanks so much. You've kind of said a lot of what I was hoping to say. So, I think the exciting thing about this particular, presentation today, if you look at the developmental arc of PHSSR, right? We started out, in the early 2000s with basic descriptive research, looking at how public health systems were made up, and to a little bit of an extent what they did. And this was certainly useful. It kind of gave us an opportunity to look at. You really can get the first look at what our system looked like as a whole, right? But this really didn't let us tell us anything about best practices. And beyond that, you couldn't imply causality with any findings. We couldn't do that with this kind of research, and because it really lacked the methodological rigor necessary to even draw basic, almost associations. Now we've seen this developmental arc, move in a direction characterized by more methodological complexity, and you're using techniques such as propensity score matching and instrumental variables analysis, things like that. Nonetheless, this led us down. This gets us closer to being able to imply causality, right? Because at the end of the day, we want to know for certain whether or not what we did made a difference in public health. But some of the stuff we're doing now can help us imply causality. These techniques are only as good as the data we have to look at, and there have been some concerns regarding the internal validity and reliability of analysis using some data sets used in PHSSR. We use a lot of kind of national level secondary data, and while that data is certainly useful, it's let us make, I think, great strides in public health. It's not necessarily the quality one might want for drawing kind of inferences regarding causality. And given too, we've primarily limited ourselves, at least in the early days of PHSR, to looking at existing secondary data sets. That really limited us, in our ability to examine the system to a large degree to looking at the governmental public health agencies. The nature and ASTAR profiles are so useful to us in PHSSR, but they really give us an idea what the governmental public health agencies do. They don't really give us an idea what the public health system, writ large might be doing or not doing. And that, in my mind, is why this research project is so interesting and exciting. Using these pragmatic randomized trials, such as the one discussed today, allows us to get even closer to the gold standard of randomized double-blind control trials, which don't exist in real life, as we know. So we get closer to that standard, but we also get a chance to accommodate the limited resources available to many public health practitioners and researchers. In the real world, we don't have the time and money necessary to conduct an RCT. These trials can be done very quickly, and they're relatively cheap, and they're conducted in a real-world setting, so you get a lot of bang for your buck. You get a lot of juice for the squeeze, as Glenn Mays would say. In this real-world setting that they take place, it might be the most important part of the pragmatic trial. While the main concern regarding, your gold standard RCT is weak external validity, this is much less of a concern here with this type of trial because it takes place in a practice setting, right? This is taking place in the real world, and it accounts for the context of public health practice. The pragmatic trial that we're looking at today, reflects what one can reasonably expect to encounter, what policy and practice choices are actually available to public health practitioners on the ground, folks who are actually doing the work, to make the public healthy. The nice thing with pragmatic trials is they also let us randomize beyond individual patients and kind of work at, the team organizational, multi-organizational system, and even community level. So it lets us look at, it gives us a lens much broader than just the lens you get by looking at individual patients. So, honestly, I'd suggest that given the vast array of changes taking place in U.S. public health system and healthcare systems today, ranging from healthcare reform, in significant reorganizations, efforts taking place due to changes in political leadership at the state and local levels, these pragmatic trials, like the one discussed today, give us a great opportunity to develop the evidence base for public health agencies to apply, to assure adequate resources and the use of best practices in public health practice. These trials give us an opportunity to really, right now we've got opportunities to look at what variations in practice and service delivery what implications that might have. These trials are, I think, a great way to examine it. So, again, I think this is a fascinating project, and I think it's a great model for us to use to kind of examine not just, system delivery issues like Dr. Kempe looked at today, but also issues that Lisa alluded to taking place kind of at an organizational level as well. So yeah. So thanks so much again. So Allison, do you have any response to what Lisa and I have said today? Any thoughts on that?
Yeah, actually, I'd love to respond to a few things that were said. Number one, I didn't present all the preparatory work that went into allowing us to do this. And I'm glad Lisa brought that up because we did a fair amount of qualitative work with public health department people, with parents, with physicians, to help us design the messages, to help us think through any problems, and to build cohesion so that it wasn't a surprise. The other thing is that Lisa actually was very helpful in introducing me to all of the county health departments. I went to a couple of big meetings and presented this. So I do think that foundation work was extremely important, and it wasn't all easy. I mean, there were a couple of counties, you might be able to predict them if you know anything about politics in Colorado, that were like, no way, we don't want to be involved in this. So, it wasn't always easy, but I think that work was very important, and it also built incredibly strong bridges between us and particularly the state health department. We have now done 2 additional trials. We have another one ongoing right now using these methods within the RICO populations that Lisa brought up, within the ACOs, to examine this methodology, not just for young children, but for adolescents and for adults. And we have 2 other grants that I hope are going to be funded looking at reminder recall for HPV throughout the state and for influenza. So we've been able to really build on these relationships, and it's sort of mutually beneficial at this point. The other thing I do want to comment on is the funding piece. We've shown that this is much cheaper, but it still has a cost. And, public health departments are completely strapped, and So are private practices. They don't even realize how much money they're spending when they try to do reminder recall on their own. So if we sort of make this a collaborative, centralized process, how do we pay for it? And I guess from my perspective, obviously when you've got something like an ACO, this is a cost-saving measure to immunize. I mean, there's so much data showing how much cost saving there is associated with immunization, both for children and adults. So that may be one of the mechanisms. But it does seem as if it gets cheaper and cheaper as the data systems get more efficient and aligned, for example, as more practices are HL7 compatible and there's bidirectional information going from practices to the registry and back, so that we have to spend less and less money and time with incorrect contact information. This could all get so much cheaper, but it's still, I think, going to require some kind of a collaborative model where everybody kicks in a little bit. And I think that that's sort of the end game from where I sit. That's what I hope would happen. I do want to say one more thing, too. Lisa brought up other methods of collaboration. And this study, shortly after this study, we tried something else with several of the county health departments. We tried an experiment, another pragmatic trial, in which we randomized practices to either doing flu delivery on their own or to a collaborative method where the county health department and the practice work together to try to get, the entire population of the practice immunized. And this was an example of a much tougher pragmatic trial because we encountered a whole lot of problems that we didn't expect, all to do with issues about purchasing vaccine, having concerns about the practice not being able to use up their vaccine, all kinds of problems with collaboration that were very interesting and very important. But we're talking about the wonderfulness of pragmatic trials. They also really are challenging sometimes because you do really come up against those tough issues about, you may think collaboration's a wonderful idea, and I actually came up with the idea for this grant. I thought it was going to be this great, wonderful collaboration. It turned out to be extremely difficult to do. So I just think we've had a lot of spin-offs, and it's been, I believe very strongly in this collaboration.
We're open for questions now, but I have a question, Allison. So given what you've just said, let's circle back there. Let's say we had some folks on the phone today who are interested in kind of applying, this technique to another research project. What would your suggestions or kind of, advice, what advice would you give them when they're just kind of starting up there, or just even thinking about the research project? What advice would you give them to make it work smoother for them, if that makes sense?
Well, I think, first of all, if they're using a registry, it's important to, using a mature registry would be very important. So I think the system would be very tough in a state where their registry is very new and incomplete, because then you're using pretty bad data. So that's number one, figuring out how mature the registry is, how accurate the records are likely to be, and then beginning the collaboration with the health. Usually the IIS is based in the health department, so beginning that collaboration. Another way this could go, of course, is within an ACO or within a closed model HMO. I mean, that's the same idea. So it's all about how accurate the data is and how much cooperation you have with that data system. So we certainly, all of the registries have the forecasting ability to generate reminder recall reports, or to actually, even many of them, to generate the postcards. So that's not, virtually all of them have that capability, to my knowledge. So this is possible to do in every state, but there are different levels of maturity and participation in the immunization registry. So that's one important issue. And forming the relationships, I think, would be the other. We would be really glad to give assistance to anybody who would like to do this, including information about how we tracked reminder recall. You know, we had a system, a system where we tracked how many, you know, we'd sent out, returned addresses. You know, you have to pay a little bit of attention to that system, and we'd be glad to share all of that information with any.
Great. And again, we're open for questions. So if you have questions, please just type them into in the chat box on your screen here. So we do have one question, Allison. Ann Kelly wanted to know, she says, Dr. Kemp, was the second study conducted in the same or different communities than the first study? So you presented kind of two different studies. So the second one was the first. Was it the same communities as the first or different?
Many were the same. There were a few different, but many were the same. And the second study that we did showed, I mean, it was the same results, but a little bit less effectiveness. And I think that was, number one, we started at about 15% higher overall immunization rate. So we were getting to the point where we may have been weeding out some of the people who weren't going to respond to a simple reminder recall, and we needed to, you know, to go to the next level, and there's certainly many levels that you need to go to if you're trying to get everybody. So I presented the first one because I thought it was more typical for most states. You know, first time you're doing it and your immunization rate is sort of lower. But yes, many of them were the same.
Great. Okay. Any other questions? So I have a question. I'm looking at your slide, which is, you know, has the pie charts comparison of the reach of the intervention, and you've got, it looks like, you know, it with your, and maybe I'm reading this slide wrong, but it looks like with your population-based approach, almost 85% of the children eligible, you know, received a notice, whereas the practice-based reach, it looks like roughly maybe 5% of the children available received a notice. And it just seems to me like that's a huge, I mean, the difference there is just huge. And that would suggest to me that the population-based approach just is a sheer numbers game, is a really kind of a much more, well, it has potentially a much more effective method. Would you agree with that?
Well, you know, of course, we don't know that 85% were reached. That's our estimate based on,
that's the estimate, yeah.
We no longer got returned mail. Initially, a lot of incorrect mail, and we, you know, did that process. So yeah, I mean, the lesson here is not that practice-based reminder recall doesn't work. It's that if you're trying to increase rates for a population, it's not going to work as well to put your efforts on trying to get practices to do this. You know, trying to have every little private industry learn how to do this just was not effective. But and maybe that seems, it sort of seems like a big duh to me now, but honestly, there has been so much push from the CDC and from all the preventive organizations. There has been so much focus on the practice for a lot of years, and I think there are something like 25 randomized trials at the practice level showing the effectiveness of this. So, you know, it really is time to think outside of the box a little bit, because yes, it works, but if people won't do it, it doesn't matter.
Great, thank you. It looks like we've got another question. Someone did type in a question, will there be a copy of this presentation available to download at a later time? Anne, I believe there will, correct?
Actually, the slides are available in the upper right-hand corner of your screen where it says presentation February 4th. You can download from there, and yes, we'll have a recording of this presentation. It'll be up on our website within a couple of days. And on the next slide, we'll actually has the link. But I think the other question I had for Dr. Kemp is that, are there other areas that you think this approach would work other than immunizations? Some of the other patient education areas or
I think there
communicable disease?
I think there are definitely other areas where this would work. I think collaborative interventions involving the community, public health, and the practice are the most effective ways, first of all, to accomplish things like preventive care, where it's often simply a question of getting people in. I think places where it doesn't work is more complex management of patients with, chronic conditions and that kind of thing. And that needs to, I think, firmly remain within the primary care side. But there's so much of what we need to do in primary care, particularly in the preventive care realm, that is probably best accomplished outside of the practice, certainly in collaboration with the practice. But if you think of the type of screening we're trying to do all the time in practice, and things like immunization delivery or, colon cancer screening, blood pressure checks, all kinds of preventive care, a collaboration with public health would be so much more effective and efficient. So I think, yeah, particularly in the area of preventive care.
Thank you. Looks like there are no more questions. So I'd like to thank you again, Allison and Lisa, for your participation in the webinar.
Great.
We appreciate you being willing to present and comment. Our upcoming PHSSR Research in Progress webinars in February, we've got one next week, Cross-Jurisdictional Shared Service Arrangements in Local Public Health, Research in Progress by Susan Zahner and Kusuma Matamala. And then on Thursday the 19th, we've got Identifying and Learning from Positive Deviant Local Public Health Departments in Maternal and Child Health by Tamar Kleiman from the University of Sciences in Philadelphia. And then we've got like a few in March as well, and a few in April. And then don't forget, Tuesday and Wednesday, April 21st and 22nd, will be the 2015 PHSSR Keeneland Conference in Lexington, Kentucky. I believe registration is still available. For more information, please contact Ann Kelly, the project manager. Here's her information on the screen. Thank you so much.
Dr. Ingram?
Yes.
I'd be very glad for anyone to contact me. Can you send out my email?
We'll do that. We'll do that. Thank you.
Okay, great. Thank you so much for having me.
You're welcome. This is Ann. It's actually included on the speaker bios as well.
Wonderful.